in the neurointervention. Has a very excellent results in both the stroke and in the malformation aneurysms. Please, Dr. Farouk.
Thanks, our Professor Ahmed Sami. So I'll be talking about the AVM when we have a flow-related aneurysm with an AVM and our approach of management in such case. So we know that the incidence of aneurysms associated with brain AVM reported in the literature from 2.7% to 58%. And we can classify the flow-related aneurysms with an AVM as prenidal aneurysm, what we call a prenidal, which is an arterial aneurysm, intranidal aneurysm within the AVM nidus, and postnidal on the venous outflow of the AVM. And regarding the prenidal, the arterial aneurysms, we can classify them as a proximal and distal. Proximal, what we mean by proximal flow-related aneurysm is an aneurysm at the circle of Willis level, at the ACOM MCA bifurcation, but on an artery supplying the AVM. Distally located flow-related aneurysm is an aneurysm on the feeder itself, a little bit more distal than the circle of Willis, but on the feeder going to the AVM. And from the literature also, we know that the incidence of a prenidal aneurysm associated with a brain AVM, a prenidal, I mean arterial aneurysm related to an AVM, ranges from 7.5 to 12%. Many studies in the literature try to find the relation between the presence of a flow-related aneurysm and the risk of hemorrhage of an AVM. We have multiple series. One of them, one of the biggest of them is the series of Michel Putin and the team of Rothschild at that time in 2001, when they published the results, and they found that when we have an AVM with a flow-related aneurysm and we have a rupture, 80% of cases is caused by rupture of the flow-related aneurysm, not the AVM, and 20% is caused by rupture of the AVM nidus itself. And also they found also that when we have an AVM without flow-related aneurysm, the risk of bleeding in those patients was about 27, not the risk of bleeding, the presentation by hemorrhage in their series was about 27.5% when we have an AVM without a flow-related aneurysm. But when we have an AVM with a flow-related aneurysm, 50% of those patients presented by hemorrhage. So they found a significant relation between the presence of a flow-related aneurysm, whether it's a prenidal or intranidal, with the incidence of hemorrhage in the series of AVMs they had. And this is actually an important information because actually we know that for example, when we have an AVM with flow-related aneurysm and we will treat this AVM in multiple sessions, having a flow-related aneurysm, whether it's a prenidal or intranidal, when we know that it carries the highest risk of hemorrhage from this pathology, I think that if we are going to do multiple sessions, we have to prioritize the management of this flow-related aneurysm first in the first session, and then we continue treatment afterward. This is one point. The other point is that we know the Aruba trial that was done for the non-ruptured AVM, the Aruba trial did not stratify the AVMs according to the presence of flow-related aneurysm or not. But we know that the Aruba trial led us to take, let's say, a step backwards in the management of the non-ruptured AVMs, and we are now evaluating case by case to decide whether to treat a non-ruptured AVM or not. So when we know from the literature that having flow-related aneurysm carries maybe a little bit higher risk of hemorrhage from this AVM compared to an AVM that does not have a flow-related aneurysm, I think this is one of the important factors that we can put into consideration when we want to decide whether to treat an unruptured AVM or not. And that's why also I'm always saying that if we have an unruptured AVM that we saw in a CT angiogram or an MRI, and we decided preliminary not to treat this AVM because maybe it's a large one, non-ruptured, we have to take this decision after doing a conventional angiogram. It's not enough to depend just on CT angiogram or MRI to take a decision not to treat an unruptured AVM. So we have to go to do an angiogram and to find if we have weak points that carries a little bit higher risk of hemorrhage, and then after doing a conventional angiogram and studying the angioarchitecture of the AVM properly, we can decide whether to treat or not to treat. So what is our treatment strategy? When we have a prenidal arterial aneurysm, it may be proximal as we mentioned. If it's a ruptured aneurysm, patient presenting by rupture of an aneurysm around the circle of Willis, which is considered to be a flow-related aneurysm with an AVM, so we go for urgent coiling as we do with any ruptured aneurysm. If it's a non-ruptured aneurysm and we discovered the aneurysm when we are studying the AVM, we do elective coiling, and we prefer in most cases to do this before doing the AVM treatment. Like what we did in this case. This patient had an AVM supplied by the right MCA, and we can see that we had this aneurysm at the bifurcation at the proximal part of the M1 segment of the right MCA, and then the branches of the MCA were supplying the AVM. So we decided to start first by occluding the aneurysm and then to continue treatment of the AVM that we see here afterward, after we occluded the aneurysm first. This patient had this AVM. It was a left thalamic AVM, and it was ruptured with intraventricular hemorrhage, and we decided to treat the AVM. We went first doing first session of transarterial embolization, and it went well, and then 2 months later we were planning to do the second session. And just a few days before doing the second session, the patient started to complain from acute third nerve palsy with ptosis and lateral squint. And then we did a diagnostic angiogram, and we found that the patient developed this aneurysm that was not seen before. It was a little bit strange because we just did a diagnostic angiogram and embolization 2 months before, and we did not have this aneurysm, and we occluded already part of the AVM nidus, so it was not clear why the patient developed just in 2 months this aneurysm with acute onset of symptoms, maybe because the flow increased after we occluded part of the AVM, the flow increased maybe in other arteries, I don't know. But at least we know that this aneurysm now carries a high risk of hemorrhage. It's an aneurysm that developed in a very short period, and the symptoms occurred in an acute fashion. So we decided to go and to treat this aneurysm by doing coiling, and then a few weeks later we went and we did another session of embolization of the AVM. What if we have a prenidal arterial aneurysm but in a distal location and the patient presented by hemorrhage? So we know from the literature that in many cases it may be the aneurysm that ruptured, not the AVM nidus. So if we are sure that the aneurysm was the site, the origin of the bleeding, we go and we do urgent embolization for the aneurysm, mostly by injecting glue, because it's a distally located aneurysm. So we go by a microcatheter into the feeding vessel and we inject glue to occlude this ruptured flow-related aneurysm. We have to go back to the CT scan to check the site of the hematoma and compare the site of the hematoma with the site of the aneurysm and the AVM to decide which one was the origin of the bleeding, to choose the priority for the management. Like what we had in this case, male patient, 45-year-old, presenting by subarachnoid hemorrhage, mainly in the posterior fossa. And then we did the angiogram and we found this AVM, and the patient had this trifoliate aneurysm, flow-related aneurysm from the superior cerebellar artery. And when we went back to the CT scan, we were sure that this was the origin of the bleeding, so we decided to treat this aneurysm. We went by our microcatheter into the superior cerebellar artery, and then we injected glue. We occluded the aneurysm and the feeding vessel. And then we have the AVM. We can decide later on what to do with this AVM. We can do another session of embolization if we have an accessible access for it, or it can be treated by gamma knife or surgery. So we'll decide later on, but at least in the acute stage, we occluded the origin of the bleeding, which was the flow-related aneurysm. Same for this case, the patient presented by subarachnoid hemorrhage, mainly in the posterior fossa. And we did an angiogram, we found the AVM, and we found this flow-related aneurysm. And we knew that this aneurysm was the site of the bleeding, the origin of the bleeding. But in this case, I decided to do a fancy procedure and to occlude the AVM and the aneurysm in the same session, if it's possible to go distal to the aneurysm, reaching the AVM nidus by the microcatheter in a safe way. And it was possible. I was able to go with a microcatheter distally and to reach the AVM nidus. Here we have our microcatheter, and then I decided to inject onyx to occlude the AVM. And finally, the AVM was occluded completely. I retrieved my microcatheter very slowly, and then I do the control angiogram, and I find that the aneurysm ruptured. And now I realize that it was not a good decision to inject the AVM and then to retrieve my microcatheter through an artery that carries a flow-related aneurysm that was already ruptured. So I went immediately by another microcatheter, I occluded the artery, and we had this hematoma. The patient clinically later on was okay. He had some ataxia that improved significantly within a few weeks. So the patient was lucky, but I think it was not a good decision to decide to inject the AVM and then retrieve the microcatheter from a branch carrying a flow-related aneurysm. Similar situation maybe in this case, female patient, 32-year-old, presenting by cerebellar hematoma, and we did the angiogram, we found this AVM, and we found also this flow-related aneurysm. And we can see pointing at the fundus of the aneurysm. And when we went back to the CT scan, we were quite sure that this is the origin of the bleeding, so we decided not to make the same mistakes that we did before and try to embolize the AVM and the aneurysm in the same session, but just the aneurysm, which is the origin of the bleeding. This is what we did. So I don't know why the video is not working. Okay, so we had a video here showing the injection. It's not working anyway. So and we injected our glue. So we occluded the flow-related aneurysm and the feeders, part of the AVM. It's not important, but at least we secured the origin of the bleeding, and then later on we'll see what to do with this AVM. We may have also a prenatal aneurysm, but it's a non-ruptured one that we discover when we do the angiogram. So we make our decision actually according to the size of the aneurysm and the possibility of its occlusion. I mean, if we have a sizable aneurysm or an aneurysm which is very proximal to the AVM nidus, we can occlude it with the occlusion of the AVM. But if we have, let's say, what we call a dysplasia of the vessel, not a true aneurysm, we can just occlude the AVM and then the artery will shrink after occlusion of the AVM because the flow will be reduced in the artery feeding the AVM after its occlusion. This is what we did in this case. So it was not a ruptured aneurysm here. We have the flow-related aneurysm on the pericallosal artery, and we have this small AVM. So we went through this plastic vessel. We occluded the AVM. It was not a ruptured aneurysm. We tended to have a very short reflux to avoid having forceful traction of the microcatheter across this vessel, despite that it's not a true aneurysm and it was not ruptured, but also we had a fear of having its ruptured. So we occluded the AVM, as we can see. The AVM is completely occluded, not a big reflux. The microcatheter was retrieved easily, and then we have the flow on the artery that is significantly reduced, and we are sure that the risk of bleeding from this dysplasia will be lowered. What if we have an intranidal aneurysm? So if we have an intranidal aneurysm and we have a ruptured AVM, we have also to go to the CT scan and to check whether this intranidal aneurysm was the origin of the bleeding or not. If it's the origin of the bleeding, we have to go and to do an urgent embolization of the AVM, starting by embolizing the compartment of the AVM carrying this intranidal aneurysm. If we are able to occlude the whole AVM in one session, it's not a big one. We can do this, occluding the AVM and the intranidal aneurysm. If we cannot occlude the whole AVM in one session, so we go in the first session and we try to occlude the compartment carrying the flow-related intranidal aneurysm that ruptured. Like what we had in this case, the patient had left temporal hematoma, this AVM, we do the angiogram, supply coming from the MCA and also from the PCA, and we found this flow-related aneurysm, and from the CT scan, it was the origin of the bleeding. So we went by our microcatheter, we reached the aneurysm, we injected our embolic material, and then we occluded the flow-related aneurysm and part of the AVM nidus, and then we will decide what to do with the rest of the AVM, if it's possible to continue its treatment or not, but at least we secured the weakest point of this AVM. Same for this case, partial embolization in another hospital for this AVM was done, and then the patient bled again after the first embolizations that they did. We did our angiogram and we found the daughter flow-related aneurysms here related to the AVM nidus. So we decided to start by injecting those aneurysms. We went with our microcatheter here, we injected our onyx, we occluded, or I think it was, I cannot remember, it's onyx or glue, and finally we occluded the daughter aneurysms and we secured the weakest point of the AVM. Sometimes also we may have a non-ruptured AVM, as we mentioned when we were talking about the Aruba trial, but we find in the AVM that we have a flow-related aneurysm. So if we are able to occlude the AVM completely, we do this. If we are not able to occlude the AVM completely, we can and we decide to treat it completely, but in multiple sessions. So we have to start first in the first session by occluding the compartment of the AVM carrying the flow-related aneurysm. And sometimes we have a big AVM that we cannot treat completely, but we find a flow-related aneurysm within the nidus of the AVM, so we can decide to go and to do what we call targeted embolization, where we occlude the weak point of the AVM nidus, and then maybe the rest of the AVM nidus will be left for conservative management. So we evaluate the condition case by case. Like what we had in this case, big cerebellar AVM, but it's non-ruptured AVM. It's difficult to occlude it completely, and I think it will not be without risk, but we had this flow-related aneurysm. So we decided to go to occlude this flow-related aneurysm, targeted embolization. We occluded the aneurysm. We are not tending to occlude big part of the AVM because we know that we will not continue its treatment till the end, but at least we occluded the weakest point of the AVM, and then we stop, and I think that we reduced the risk of hemorrhage from this AVM. What if we have a venous aneurysm, post-nidal aneurysm? Actually, what we do is that we treat the AVM. We don't treat the venous aneurysm for sure, like what we had in this case. So we had this AVM, and we have this venous aneurysm, large one, lateral view. We can see the AVM and the venous aneurysms. From the posterior circulation, posterior cerebral artery also supplying part of the AVM, and we can see the venous aneurysm. So we went by transarterial approach. We occluded the AVM completely by injecting our onyx. And finally, we have occlusion of the AVM, as we can see from the anterior circulation here, and also from the posterior circulation, and that's enough. We don't have to infiltrate the venous aneurysm by the onyx. We just occlude the AVM, foot of the vein, and the feeders, as we do with any AVM. Same for this case. It was a post-surgical residual of an AVM nidus. We had this venous aneurysm that we can see here. So we managed to find a way to reach the AVM nidus by transarterial approach. We injected our onyx, and this is the control angiogram where we occluded the AVM completely, and we get rid of the pathology. Thank you.
Thank you, Dr. Farouk, for this comprehensive presentation of the flow-related aneurysms in AV malformations, the different types and how to approach. Anybody has a question?